Hello, my name is Kristen Childress. I'm an associate teaching professor in the School of Nursing here at the University of Washington. I'm also one of the co-directors of the Palliative Care Training Center. This talk will be on comfort care at the end of life, and it's based on inspiration from Dr. Caroline Hurd's excellent talk, Comfort Care from Drips to Boluses and Beyond. That talk is also included as optional viewing in this module. So if you prescribe, and then especially if you work in the inpatient environment, I would really encourage you to take a look at that presentation. It includes wonderful information about order sets and related content relative to addressing end-of-life discomfort in the hospital setting. In this talk, we're going to be stepping back a little bit and getting a broader view of the concept of comfort care, including what it is and how it can look a little different depending on what practice setting you're in. So our objectives for today include, following this talk, include describing what the term comfort care might mean at the end of life. Hopefully you'll be able to list three principles of comfort care and be able to discuss two ways that the use of systems can improve the quality of comfort care provided. So I want to start us out by sort of leveling the playing field and grounding us all in the same space. I would like for you to consider, what is comfort care? This might bring up several different ideas for you. How would you define this or discuss this with a patient or maybe even a colleague? I'm going to give you a moment to go ahead and write down some of your thoughts. Feel free to pause this presentation if you need to. Well, hopefully you have a few thoughts. And as we enter this time together talking about comfort-focused care, let's talk about it from a broad standpoint, okay? So when you think about the term comfort care, it might bring up, as I mentioned, several ideas. If it does, you're not alone. When we look in the literature, when you do a search, comfort care is most often correlated with palliative care. So if you do a search, you might not see comfort care listed specifically as much as palliative care as sort of a proxy, which I think is a little bit interesting. I mean, the two terms can be used interchangeably in certain ways. Philosophically, they certainly align, right? So when we think about comfort care as including relief from symptoms and improving quality of life, as well as avoiding any treatments that might cause pain or distress or that detract from quality of life, that matches with palliative care. Considering also whether treatments align with values and goals of care is obviously a core premise of palliative care. However, I take care of many people whose care is comfort-focused, but who are not on comfort care. So I work in the outpatient setting. And so I have many people who are living with serious illness who have made it very clear that they do not want a lot of life prolonging measures. However, they would certainly entertain short-term interventions or measures that might help them get over an acute illness, for example, or address another underlying issue that can be reversed so that they can continue on with their previous quality of life. I feel like this is an important differentiation from comfort care at the end of life, which is really what we're going to be talking about for the remainder of this presentation. You might also hear this referred to as comfort measures, especially in the inpatient setting. You might also hear this referred to as symptom management at the end of life. And I wonder philosophically if this is really the best way to frame this topic, in the sense that, yes, we're addressing symptoms, but that often makes us think just about the use of medications. And really, when we think about comfort at the end of life, we're thinking broadly about things even like spiritual distress or interpersonal distress, which may be detracting from somebody's quality of life and may require some intervention in order to make sure that the end of their journey is the way that they would like for it to be. This is part of the reason that hospice services in the outpatient setting are usually employed for comfort care at the end of life, because they include all the different professions as well as different modalities in order to meet all the myriad of types of distress that somebody might experience at the end of their life beyond just physical symptom issues. There's ambiguity in this end-of-life care terminology. Again, even when we talk about comfort care at the end of life, that can mean lots of different things to different people as far as what do we do, what do we not do? And I run into this frequently. There was this JAMA article in 2018 that's really excellent, and it talks about how when people have a designation as being on comfort care or receiving comfort measures, that there's a risk that all of a sudden their care will no longer be individualized, and instead they will just have sort of cookie cutter end of life care. And this can lead to really very sad, actually, outcomes that are not patient-centered and could have been done very differently and very much better. So examples that were given in this article include even continuous morphine infusions in somebody with renal failure, which was absolutely not appropriate if they, aren't able to clear that morphine, and things like deactivating a dual chamber pacemaker that is supporting cardiac output, which in and of itself may be helping promote that patient's comfort. And unfortunately, because of these different approaches to what comfort care means, it has created not only confusion among both clinicians and patients as well as their family members, but also concern that if we designate somebody as being on comfort care, that they won't receive an individualized plan of care, and that we're just going to let them die or even hasten their death. So let's define this a little bit more specifically so that, again, we're using the same thought process as we're talking about the concept of comfort care at the end of life from here on out. So this is my definition. You aren't going to find this published. Maybe I should at some point, but I define comfort care as care where comfort becomes our primary focus, really setting aside interventions that are intended to cure or to promote longevity of life. So we're shifting from that longevity focus and that cure focus, which may not even be possible, to comfort. Other definitions that I did find in the literature include care that improves the quality of life by relieving suffering and providing practical, emotional, and spiritual support. So that alludes to some of what I talked about a moment ago, as distress being broader than just physical suffering. And another definition is care that is focused on symptom control, pain relief, and quality of life. Really, it's an acknowledgement when we think about comfort care at the end of life. It's an acknowledgement that death will be the outcome in this situation, and that we're no longer trying to fight off death as the enemy. We now have a new focus. We'll talk more about that in a moment. In 2018, Barbara Bush her family made a public announcement that she had made the decision to go on comfort care at the end of her life. And there was this article that was published, written by a physician and an RN, that was really excellent and explored how the publicizing of this event actually really drew a lot of attention to comfort care as a form of care, but also raised different conundrums as well. But this quote that was in the article is just lovely, and what the author said is that comfort care prepares us to face the last phase of our lives and creates space for us to reach out and connect. What comfort care really means is a different kind of intensive care, one that treats pain, strengthens coping, and opens lines of communication, love, and spiritual connection. As I said a moment ago, it's really an acknowledgement, the authors say, that death is the outcome and that we're no longer treating it as the enemy. But one of the misperceptions can often be that then we're just giving up. And actually, comfort care is a signal that we're just changing our hard work to be focused in a different direction. Any of you who've worked with patients at the end of life know that it often does require a lot of work and diligence to ensure that patients' symptoms are well controlled and that their quality of life matches their wishes. This is not cookie cutter. It often requires a lot of really close attention being paid to the patient and their symptoms and their comorbid conditions, and fine-tuning what we need to do in order to achieve the level of comfort that they want, even while also providing them, for example, a level of alertness that they may want. So, for example, some patients may want to be completely comfortable, regardless of whether or not that means that they're sedated and unable to interact with those around them. And other people, as their goal, really try and want to balance that quality of life piece with also being able to engage with the people that they love. And while this is an amazing goal and certainly one that as clinicians we all work to support, it can be difficult. So again, it's not that we're not doing anything, it's just that the focus of what we're doing shifts. So let's think for a moment about the principles of comfort care. And really, these principles include proactive treatment of uncomfortable symptoms, like we've talked about. And I think that's what comes to mind for most of us when we think about comfort care. But it also includes, in addition to medications to promote comfort during the dying process, the discontinuation of other interventions, which could include tests, procedures, or medications, which are detracting from or not contributing to comfort. It also allows for activities that contribute to quality of life, even if they might be life-limiting. So again, if we're not treating death as the thing that we're trying to avoid ultimately, but instead trying to achieve that balance of quality of life, even if it tends to affect longevity, we can think about things like recreational eating for people with dysphagia. So even though that might shorten their life, if they are eating, say, regular foods or drinking non-thickened liquids because it's more pleasant for them, it increases their quality of life potentially, and that's a reasonable trade-off for that person. There are common misperceptions around comfort care. One is that people on comfort care can't ever receive antibiotics, for example, or that they wouldn't receive any medications for chronic conditions. Often people will think that just because you're on comfort care, you couldn't possibly receive tube feedings or IVs. And many people think that you shouldn't or couldn't receive advanced interventions at all. And this isn't true. This, again, it needs to be patient-centered and must be in alignment with their goals of care and their wishes. So, for example, I've had patients who did continue on antibiotics to the end of their life. And in that situation, the antibiotics weren't often being used for cure. We didn't expect that that was going to fix the person's problems, but it was being used to try and keep an infection under control, say osteomyelitis, so that the person maintained the highest level of comfort that they possibly could, even knowing that that infection was ultimately likely going to take their life or contribute to the end of their life. Certainly we keep people on medications for their chronic conditions. We try and be selective, right? So especially in the outpatient environment where people may still be able to take oral medications for a period of time at least, thinking about how we address pill burden and the task of having to take a bunch of pills, especially when we know somebody's life is limited, with also what might happen when we discontinue all those medications. So there may be medications, again, for example, for heart failure, that we know if we discontinue those, the person may actually experience more discomfort than they would than if we just left a couple of those medications in place. They wouldn't be life prolonging, but they certainly could contribute to comfort. Right. I think we've talked actually in some of our cases, or you've seen in some of our cases here that we've gone through, in workshop and in webinars, that we do sometimes consider tube feedings or IVs in the right situation when patients or family members are fully informed about what that means for that person and the risks involved. Even if we know that it's not likely to contribute to overall quality of life or longevity. Again, longevity isn't our focus at this point, but it doesn't mean they can't have it. And then again, often people will think that someone can't have any advanced interventions at all, and some people may benefit, for example, from things like BiPAP at the end of life, if that is providing them a level of comfort that they otherwise wouldn't have if that was discontinued. So the easy thing would be to rotely discontinue all things and not provide any intervention because somebody has been designated comfort care. And the harder and better thing to do is really to explore what that comfort care needs to look like for that individual, maintaining all those good person-centered principles that we know about. So next we're going to talk about initiating comfort care at the end of life. In the inpatient environment and in the outpatient environment, this often involves using systems, and we use systems in order to make sure that we are providing that best level of comfort care that we possibly can. So in the inpatient environment, that often looks like starting comfort care order sets or standard order sets. And in the outpatient environment, it usually involves the same thing, but also the addition of services that otherwise would not be available to that patient, for example, hospice services. When we think about order sets, the reason for these are that they support the prescribing of appropriate evidence-based treatments. They promote the use of recommended dosages based on drug pharmacology, which is important so that we're not using too much or too little for the patient or titrating doses too quickly. It helps reduce the variation in prescribing practices between clinicians so that there's some anticipation of what is going to be provided to different patients regardless of who is prescribing. Order sets decrease the potential for medication errors, and also they often decrease the need for order for clarification, both because of legibility reasons, but also because then it decreases the likelihood that an order will get put in improperly, or that, again, there will be variance between clinicians and that something will then need to be clarified. This issue around titration, for example, was brought out in this blog article by David Weissman in 2015. And one of the highlights from this article was that a report found that morphine infusions frequently did not follow accepted pharmacological principles. And so it went into talking about how we, especially in palliative care, have a responsibility to make sure that we're using opioids according to their pharmacological principles so that nobody's confusing the use of opioids with assisted suicide or euthanasia, basically shortening somebody's life, which is a problem that people worry about even to this day. And I'm going to talk a little bit more about that misperception here in a moment. But it's something that still exists. And unfortunately, as a medical community, when we don't use medications in the best way possible, when we aren't following systems, then we run the risk of just increasing that concern on the part of patients, families, and even other healthcare providers. So comfort care order sets can be used in several different ways depending on the setting. So in the inpatient setting, it helps designate which medications are available for comfort. It helps with opioid selection based on previous use, available route, ventilator use, those sorts of things. And it also supports titration algorithms for opioid drips so that those are employed in a systematic, evidence-based way. In the outpatient environment, usually order sets are limited to designating what medications are available for comfort. And a lot of this is because of who is or is not available to help provide care at that time point. And so really that's why it's focused on medications at that time. I would argue that having order sets for other activities beyond just medications would be highly useful. So care plans, for example, in the outpatient environment, depending on where you're working, may be one way that we can get at making sure that other aspects of comfort are being addressed, but those types of order sets or systems are not employed as routinely as order sets for medications. So I want you to think for a moment, what medications do you associate with comfort care? These might come to mind pretty quickly for those of you who work a lot with patients at the end of their life, and maybe not as briskly for those of you who don't. So take a moment, jot down a couple of ideas you might have. So some of the most common medications that you're going to be seeing used for comfort care include opioids, of course, and usually we use these to treat pain and to treat dyspnea at the end of life. Most often, you're going to see the use of morphine, unless somebody has, for example, renal failure, in which case we use a different agent, typically oxycodone, because of the clearance and the metabolites that can be associated with morphine. We may also use fentanyl if somebody needs a transdermal preparation of opioid in the outpatient environment. This may also be used as a drip, sometimes in the inpatient environment. If somebody is outpatient and able to take oral medication but needs longer acting medication, they may be given methadone so that they aren't having to receive their pain medication as frequently. For agitation and restlessness, we usually use benzodiazepines. Lorazepam is the most frequent benzodiazepine that we use both inpatient and outpatient. And then for excess secretions, I find that there's some variation depending on sort of regional prescribing practices and order sets, as well as availability of medication on the market at any given time. But different medications you might see used for excess secretions include glycopyrrolate, hyoscyamine, and atropine, and most of these are given sublingually. We also will sometimes use scopolamine patches, which is a transdermal application to help dry up excess secretions as well. So these are medications you're commonly going to see in order sets. There may be others as well. For example, you might see Haldol on an order set for terminal delirium, for example, or excessive agitation. Our medication selection, i.e., not only what the medication is, but how we're giving it, is determined by several things. The most common considerations that we're going to use in medication selection include the setting that we're in. So, for example, if somebody is inpatient, we're much more likely to use IV medications as opposed to the outpatient setting where we rarely use IV medications. We need to consider previous medication use. So, for example, somebody who's not been taking any sort of opioids previously are going to need probably a lower dose of opioid to start out with, rather than somebody who's been on opioids, maybe at higher doses, where we're going to need to calculate not only how much opioid they've been receiving in a 24-hour period, but then how much more they may need as we're putting them on scheduled medication or on PRN medication for that. I already mentioned administration route. I kind of grouped that in with setting, but that's a common thing is our administration route is somewhat limited by setting. Now, in the outpatient environment, besides oral administration or sublingual, we may also use transdermal preparations of medication in order to facilitate medication administration, especially when somebody is not able to take orals as well. Occasionally, we'll use subcutaneous administration of medications. Sometimes patients will have pumps in and we can adjust their pumps to meet their needs as well. They may have had that placed earlier on in their disease process, for example. And then we also tailor our medication selection based on comorbid conditions. So, for example, if somebody has very poor kidney function, we're going to have to alter the dosage that we're using, especially things like opioids in order to make sure that we are not over medicating that person and potentially causing respiratory failure because of the medication that we're giving at inappropriate doses. I've touched on most of these things in this previous slide, but again, for opioid selection, we really are thinking about the route of administration, the duration of action. So do we need that to last for quite a long time because of who's available to give the medication or not available to give the medication, or because of peaks and valleys that a patient is experiencing in their pain control? We need to think about their previous opioid use, as I mentioned, as well as their comorbid conditions. One thing I forgot to mention on the previous slide too is we talk a lot about opioids and benzodiazepines when we think about end-of-life care, but it's important to recognize too that there's other medications that we often use for symptom control in specific situations. And this is where having, in the outpatient environment, a hospice pharmacist, or in the inpatient environment, a skilled pharmacist who really works with patients at the end of their life or who need a lot of symptom management, say in oncology, can be super helpful to have access to those individuals because they can help tailor somebody's medications really to get at the particular reason that that person is having symptoms. So one classic example is if somebody is having bone pain, for example, say from metastases, that's a situation where opioid medication, even at super high doses, may not touch that pain, as well as something like anti-inflammatory medications. And so in those situations, we may be using things like anti-inflammatories in conjunction with other medications for pain control, as opposed to just using opioids as our mainstay. Additional considerations by setting, besides just the things that we've already talked about related to medications. So this is going to be applicable much more if you're working in an outpatient setting. In the inpatient setting, usually we have the luxury of being surrounded by highly trained clinicians who are really good at their work and have a scope of practice that supports them taking care of patients, to the fullest scope of what they can do, and working in teams to where if something is beyond an individual's scope, that somebody else from the team can be brought in to augment. In the outpatient environment, that can look a lot of different ways. And so, for example, if we're talking about taking care of somebody who's living in an assisted living facility at the end of their life, the scope of licensure or certification, as the case often is, in of the staff who are working in that facility may mean that, as an example, we aren't able to prescribe medications with ranges. So, for example, in the inpatient environment, we may write an order that the nurse could administer 1 to 2 milligrams of morphine IV. In the outpatient environment in an assisted living, we can't do that. The staff have to be given a specific dose in order to administer that dose because they don't have the level of licensure and training to support making clinical decision making, making clinical decisions around that level of assessment and intervention. So that's just one thing to be aware of. Also, we have to think about the consistency of monitoring and communication. And so, is the patient in an environment where we can ensure that every shift has the same level of information about how to administer medications, how often the patient should be assessed, how um, how to when to administer medications, what to look for if they aren't classic symptoms, for example, of discomfort. And then also keeping in mind perceptions of the individuals administering medication. So, as an example, I have a patient who is on hospice living in an adult family home. And because of the concerns of the staff in that home around giving her too much morphine, as an example, they were concerned that they could kill her by giving her too much morphine. And so, because of that concern, they were not giving the morphine as often as she needed it. And in spite of education efforts on the part of the hospice nurse, there really weren't a lot of changes around that, and it was affecting the patient's comfort and quality of life. So in that situation, the hospice team ended up starting the patient on methadone, which has a longer action, and that requires not only um, less frequent medication administration, but also scheduling that medication, which is something I'll often do when I'm working with staff who may have not as high of a level of assessment skills, for example, or intervention skills. That helps take a lot of that high level decision making out of the process. So this particular patient is now on scheduled methadone and doing really well because she has the duration of action that she needs from the medication, and there's not a lot of dependence on the staff to pick and choose when they should administer that. Now we're going to move on just a moment from medications because I want you to think about this. Again, it's always easy for us to jump to medications when we're thinking about comfort and quality of life. But I want to think you to think for a moment, prior to giving or adjusting medications, what should first be addressed? So consider this, maybe make a few notes. Discomfort can come from a lot of different, it can be for a lot of different reasons, right? And many of these reasons don't actually require medication intervention. So some of them can include things like a need to be repositioned, soiled linens, or somebody being incontinent and sitting in a wet brief. Patients can have dry lips or dry mouth that contribute to discomfort. There can be excess environmental stimulation that makes them uncomfortable or distressed, and that can include things like the amount of noise that's happening around them, the temperature, the lighting, things like that. It's always important to keep in mind that there are also things that can happen that we don't see that can cause somebody discomfort that, again, pain medication won't help and actually could make worse. So things like urinary retention, even if somebody is urinating, and constipation, even if they're having bowel movements. We should also remember to step back and think broadly about what it means to treat discomfort, because there are many complementary therapies that can be really useful in the situation. So even pulling in things like pet therapy and music therapy to help promote comfort and alleviate distress might be really useful for certain patients. As we think about treating reversible causes of discomfort, it's also important to proactively address future potential causes of discomfort through things like making sure that patients have the right medical equipment that they're going to need in order to keep them comfortable. So this issue of positioning is one example. If somebody has their own bed at home and doesn't have a hospital bed, getting them a hospital bed as part of their hospice services can be really useful in ensuring that we can continue to help position them in a way that makes sure that they're comfortable and also helps support their caregivers or their care partners as they provide end-of-life care. It's also important to keep in mind that for patients who are nonverbal, we have to be detectives. And I do this a lot in my practice and have to help educate others too, that often the signs that we would expect when somebody is in pain may not be as obvious in somebody who's nonverbal. And certainly they can't tell us, right? It's easy when they can tell us, but as people near the end of their life, it's not uncommon that they won't be able to. And so there's different tools that can be used to assess potential levels of pain in somebody who's nonverbal. And these are some of the frequent categories that can be assessed using these different tools. We're going to move to a slightly different topic, really, for a moment. And we're not going to dwell on this for too long, but I do want to bring it up because it's a common topic when we are thinking about the end of life. And that is thinking about nutrition and hydration at the end of life. So some people think that IV fluids might be really useful for their family member. Maybe they would, maybe they won't. I don't think, as we've talked about, that there is a perfect answer across the board for every single person. It needs to be shared decision making between the patient and the team or the family and the team with really good information provided, right? What about things like continuing to use thickened liquids or altered diet textures when somebody is having trouble swallowing? So we know that if they have regular texture diet or thin liquids that they're going to aspirate, which could potentially shorten their lifespan and cause them distress. But often, I don't know if you've ever tried thickened liquids, they're disgusting. and so often people won't want to drink thickened liquids. And even that in and of itself can contribute to dehydration, interestingly. So it's worth thinking about whether that matches with goals of care at the end of life. And then there's the whole issue around tube feeding and whether or not this is consistent with end-of-life care. We know that in many situations, it does not actually promote quality of life nor longevity and can actually decrease quality of life and cause more distress as well as more problems for the patient. And so again, it has to be a conversation, but there's no 100% right answer all the time. So one way to approach this that this is an approach most of us will take at the end of life, is if somebody is awake and alert, we offer food and water. If they want to eat and drink, and even if they want something other than water. So I've had patients who at the end of their life, they've been restricted from having their beer every evening, for example, because of medication interactions and different things. At the end of their life, they can have their beer, and that's okay, even if we know that there's a potential for aspiration, or even if we know that, normally it wouldn't be recommended from a medical standpoint. If that's bringing them joy, that's probably okay. We will typically allow recreational eating. And so what that means is even if somebody can't have a full meal because of aspiration or because they're not hungry, but if they just want to taste it on their lips or even use a little syringe to get the taste of something in their mouth, we'll do that. Certainly giving good oral care. I really want to emphasize this. I have seen patients who were not getting good oral care, and especially at the end of life, secretions can be really tenacious and thick, and they can almost end up with, a combination of pill fragments and all sorts of things coating their mouth. And so it really can provide a lot of relief for patients if we're making sure they're getting good oral care and just having their oral mucosa moistened. And then if somebody's in a situation where they are receiving artificial nutrition or hydration, we need to be talking with them or their family about the reasons we would discontinue these things. And that would be if the person is developing fluid overload, so pulmonary edema, for example, where we know that in that situation, IV fluids, TPN, tube feedings are probably just going to continue making that worse. Those would be reasons we would stop that. Increased incontinence that is causing, distress for the patient, even because they're having to be rolled over more frequently to be changed, that sort of thing. It's causing them GI discomfort, vomiting, diarrhea, any type of increased distress. And if we feel like it is really prolonging the dying process, so if somebody's getting a lot of IV fluids at the end of life, it may prolong that dying process, for example, considering then if then the IV fluids are actually not in line with their goals of care. And as was highlighted in our most recent workshop, we can consider a time-limited trial for these things. If this is of comfort to the family and maybe to the patient, just to try and entertain this as an idea and as an option, we can give a time trial and see, what happens with the knowledge that we can always discontinue it later. So that's the end of this presentation. To wrap it up, want you to think for a moment that comfort care is really about both an approach and a philosophy, right? And as always, it should be based in person-centered principles. We need to make sure that we're not viewing death as a failure to be avoided at all costs, which is obviously not realistic anyway. We can't always avoid death. And instead, we need to make sure that our goals are around crafting a plan to ensure that patients are being helped to travel through the end of their journey in the way that they desire. So I hope that this presentation was helpful to you, maybe caused you to think about some things that you haven't thought about before, and I would welcome any of your questions or input.